Hello from Orlando, Florida. The Sugar Queens are here on the last day of the ADA. I was so excited to be able to see all the updates and the scientific advancements of diabetes. And I think for me, the most wonderful thing was to share with my colleagues to discuss that. I always like it when we get together and we can collaborate as a collective mind. Jen, tell me about some of your highlights that you've seen.
I think honestly, there was nothing individually specific. It was so exciting and inspirational to meet with so many people and hear about the future. So I'm quite optimistic about the pipeline in terms of technology as well as drug therapy.
Absolutely. Davida.
Well, for me, the best thing is always to catch up with all your friends, people that you've known for years and worked closely with in different projects. But also the technology. Every time I think we've got what we need, there's more technology, more insulin pumps, better CGM. And then some of the information on potential side effects that we now know don't exist for GLP-1s. Some of the obesity information was outstanding. But every time I think I know what I need to know, something more comes out, and that was really exciting. And the focus on type 2 diabetes, because we really need to think about how to improve the lives of people with type 2 diabetes. So for me, that's part of what I enjoyed.
It's wonderful. And now I'm going to ask you, our audience that are tuning in, if some of you have been at the ADA this week, what did you find most compelling? What about those who are going to tune into the ADA later online? What are you looking forward to? We want to know where you're at, what part you play in Team Diabetes. So please keep your comments coming in the chat box because we want to connect with you. I'm so glad, whether you're joining us from LinkedIn or Facebook or X or YouTube, welcome to our monthly live social media event, The Sugar Queens. We are The Sugar Queens. I'm Dr. Eden Miller, an osteopathic board-certified family practitioner, diabetologist, and obesity medicine specialist. And Jen, my queen.
I'm Jen Goldman. I am a clinical pharmacist and a professor at Mass College of Pharmacy, and I've been practicing for 34 years, but this is the queen.
Thank you so much. I'm Davida Kruger. I'm a certified nurse practitioner, Henry Ford Health Systems in Detroit. I actually have been working in the Division of Endocrinology for the last 42 years, seeing people with diabetes and doing clinical research.
You can see the queens. We have quite the expert and the years of doing this. But we really invite you to stick with us for the next 30 minutes where we're going to discuss how we interpret and implement current clinical guidelines and recommendations for CGM use in our patients with diabetes. And along the way, we'll be more than happy to answer your questions. This is real time. Send us your comments. Send us those things that you want clarification in the chat box. We're going to get to them. So I'm going to set up our discussion. This is really exciting for me because I get a case. I'd like to introduce you to my patient. This is really her. I got her permission. She said, I'd like to share my story. This is a 72-year-old female. She lives alone. She was diagnosed with type 2 diabetes 15 years ago. Initially, she was placed on metformin at 1,000 milligrams twice a day, and she was currently using fixed dose mixed insulin, 22 units of analog 70/30 BID. She was also on losartan 50 milligrams and atorvastatin 20. And her vital signs when I saw her first were pretty good at 123/78. Her heart rate was 84. Her height was 63 inches and her weight was 144. Her BMI was 29.7, a little bit above ideal, but by no means into a high risk state. I asked her if she had any family history of diabetes, gestational or pregnancy or anything like that. And she indicates no. And you want to know what? Her A1C at referral was 12.7%. I was stunned. And in fact, before I really got into the interview portion with her, I asked her, what would you like to do with your diabetes? I like to do that. I like to start with that because it's not my disease. I am there to help direct the individual in their journey. And you know what she said? She said, I really feel like I'm all over the place. roller coaster. I just can't figure out what it is. Hey, Jen, what kind of questions would you want to know from this patient?
I would absolutely want to know, is she checking her blood sugars? When is she checking, and is she seeing anything?
Absolutely. I asked her that too, because she said I was all over the place, right? And I said, are you checking? She goes, yes, I check it 2 to 3 times a day, always before my meals, and I'm very good about that. But she says, I don't get a lot of hypoglycemia, but the only time I do is if I go outside and I'm working on my property.
Something's not right. Something's not right. And we have to not always blame the patient for everything.
Yeah.
We really need to investigate.
Yeah, I was thinking the same thing.
Well, and you can't see where the problem is if she's choosing 1 or 2 finger sticks here or there. And most patients don't do it when they're hypoglycemic because that's when they want to eat.
Right.
They feel crummy and they're going to eat.
You want to fix it.
Exactly.
Right.
Exactly.
And I always think of that finger sticking as you take the blindfold off twice a day and you're trying to make meaning about what's going on. Yeah, she also indicated to me too as well that she was very compliant with her insulin, because that was the other question. She said, she made me be very clear that she goes, I do what my other doctor told me. I check my blood sugar and I take my insulin. And I said, something, again, right away, right? You get those subtle little things that something's not right, because an A1C of 12, her blood sugars, she says, are going up and down. And so, Davida, what are you going to do? What are you going to look at in this individual with this kind of initial presentation? You're 3 minutes into the appointment.
Well, the first thing is I'm going to put a CGM on this patient. Whatever I have, or a professional CGM, because we do a lot of professional CGM. You have to see it to treat it, And if I don't have any data, and the woman is being as honest as she can, I mean, we could talk about 70-30 and whether that's a good therapy for anybody, but we don't even know how to make that a change until we put CGM. And so we really need to use professional CGM and use it for 7 to 14 days, 10 to 14 days, get the data back, and then, look at those. And, professional CGM, if you've never used it in your practice, is a sensor that you personally buy in your clinic, and then you can pay for placing it on the patient, and the patient comes back. You need at least 3 days worth of data, but the professional CGMs that are available are 10 days and 14 days. And then you look at the data and you can bill then for the interpretation. And that gives you everything you need to be able to move forward with some therapy.
Yeah. And in my case, I like that you said professional CGM, because to me, it's the low hanging fruit, right?
Yes.
And what I mean by that is we sometimes hear, well, I can't, what if it's not covered, blah, blah, blah. But in this individual, she is living alone, older, fixed BID insulin. It's like, this is a CGM must. Yeah. And so if you must do it, then you have options. You can do the professional, you can do the personal. I did exactly that. I said to her, has anybody ever offered you a CGM? Well, first of all, she didn't know what CGM was. So I said, it's that thing that you put and to watch your blood sugar. She goes, no. And I said, you know what, let's try one. And so I'm going to go ahead and start her on that professional one, right? I went ahead and did that in my office because I was not going to let her walk out with something. So that is how I did it. Tell me how you approach individuals with a scenario like this when you're like, you got to be on CGM.
So I think it's really critical to explain that when they're doing those finger sticks, that's just that one moment in time. And we don't know what's going on the rest of the time. So explaining that this is going to give us an idea 24/7. So it's not only for us. It's not just for us to be able to make treatment changes. It's for the patient to truly understand what's happening. What are you doing in terms of workflow? So if you do, how do you do it in your office?
And, I am unique, and I know that all of you guys are in different scenarios, and I'm in 900 square feet in Oregon at our clinic. And we still have covered wagons. And so we're a little bit in the backwoods, but no, I think for me, because I am in private practice, and I know that many of our listeners are going to be in all sorts of different scenarios. So it's so critical that you know who your team is. And for me, it's a pretty small team, but it starts at the very beginning. It's my upfront receptionist, we flag the chart to know that what type of diabetes they have, what type of CGM. We also have coded appointments for follow-up with CGM. Our staff at the very front do have a pretty good knowledge of how to download or how to get onto the different views if for some reason our MA is tied up. And then they also send out these great reminders on their additional kind of how shall I say, their reminders for their appointments. And then my MA goes ahead and downloads it ahead of time before the appointment. And so for us, it's just streamlined to do that.
Well, and I don't want people to be overwhelmed by the process of doing professional CGM.
Yeah.
We're in a bigger site than you are. We have 4
Yeah.
centers, but when we started with like 3 or 4 devices, and then we grew from them. And now that we have disposable devices, it's easier. And the other thing that in a lot of institutions, you have to at least be neutral on your cost. And if you own the sensor, you place the sensor, you interpret the sensor, and you bill appropriately, your clinic will not lose money.
Yeah, absolutely.
And so it's really important that people get something in place.
Couldn't agree more. Okay, so I'm going to turn our focus back onto the guidelines that we're talking about here. And as a reminder, our patient is on 22 units of analog 70/30 BID, metformin twice a day, and the A1C referrals at 12.7. So I'm going to tell you, when starting CGM in this patient in accordance with those guidelines, let's talk about those, Jen, okay?
Well, we're here at the ADA, so
Of course.
talking about the standards
Perfect.
of care certainly is important. And the ADA standards of care, absolutely, in a patient like this, anyone on multiple daily injections or on an insulin pump, absolutely the standards are to utilize CGM.
Yeah. Well, first of all, I'm such a proponent of CGM. I really think, and I see the guidelines and everything else going, people who have diabetes need to. It should be a right, not a privilege. But certainly the guidelines will tell you that if patients are on MDI or an insulin pump, that before you even start that, you need to start CGM. And the CGM comes at the beginning when you first meet that individual, not finger sticks, but CGM is what you really need.
To your point, we can't assume that those finger sticks that she's reporting to us are all within that safety realm. If we had an A1C of 12.7, many of our colleagues think that they are protected from hypoglycemia with that. Jen, let's address a little bit about how you're really not protected.
It's a myth. So people assume high A1Cs, you absolutely won't. So if you look at this slide, these are people on the left are people with type 1 diabetes, and you can see people with A1Cs greater than 9 have just as much hypoglycemia as those with A1Cs of less than 7. Yeah. And on the right, it's worse, it's type 2 diabetes. So you are not protected from hypoglycemia. What do you think?
I think what you have to remember is the person who's having hypoglycemia stops their medication, cuts it in half, or eats up to prevent. The person who's had a hypoglycemic event 6 months ago, there's still someone following that person around trying to feed them every day at the time that they had hypoglycemia. Hence why they often have high A1Cs. They're not taking their medication because they're so afraid of hypoglycemia.
Now, Jen, I want to talk a little bit more specifically about the standards of care and really look at that basal insulin. So comment on that, okay?
The standards of care recommend anybody on basal insulin should be offered intermittently scanned or real time, regardless. So just basal insulin, and it's going to be based on patient's preference, coverage, et cetera, but absolutely should be recommended.
Well, and it's so important that even Medicare has agreed, starting in 2023, if a patient's on 1 injection a day, Medicare will pay for your CGM. And typically, other insurance companies follow Medicare guidelines. So it's really important. And we know that patients benefit by having it. So absolutely, the patient on just basal insulin will benefit.
And I would like to say that according to the guidelines that we just go through, our patient for sure qualifies for it. Absolutely. But I would also add on to that if you're even on basal insulin, it is considered the standard of care. And so we start a CGM. you know, and when I look at that data, you know, comment a little bit about how you guys incorporate that data.
Well, so the CGM data is gathered into the cloud. We connect our patients. We do that even with professional CGM, and we gather that in the cloud, and we can look at the AGP report, which gives us average glucose GMI. Then it gives us the actual AGP report, so I can see time in range, time above range, time below range, and then I can look at dailies. So my colleagues, and there's 14 more days of data if you really wanted to, but my primary care colleagues can focus on one page. And the most important page for them is knowing time in range, time above range, time below range, and specifically start with time below range.
You know, I just want to shout out for a second because we got some fans that are right here. And Davida, we have somebody that you've seen before. I won't mention who it is, but she just wanted to shout out for you. She's had a type 1 for almost 55 years. And she said, thanks to you, you got her on CGM early, and you are her queen. And so we just want to point that out. So
thank you.
So to your point, to both of you, we're right on standards of care. Not only that, we said it's almost like we got to do this. She's got to leave on that. So here is what we saw. Here's what I saw. So 2 weeks, I had her come in. My workflow was follow-up appointment for CGM. And I will tell you, ladies, the moment I saw this, I went, something's not right. What do you see, Jen?
Oh, clearly. If you look at this CGM, it's even off the chart. So you can see it's high, it's consistently high. Interesting, the variability, it's not through the roof, but it's all high and it's consistently high. And from probably the time she wakes up and starts to eat, there we go.
Right, because she goes through the ceiling.
Yeah.
Yeah.
But
what about you, Davida?
So about 8% time in range, but Jen makes a really good point. The glucose variability is tight. And so that makes me think she is taking the insulin you prescribed.
Right.
Because if she wasn't, then you wouldn't see that tight of glucose variability. Too high, but the glucose variability is low. So it makes me think that you got to start all over with her therapies.
Exactly, because you know what? It goes back to your point. Is this the patient's problem? Or is it a diagnosis or therapy problem?
Yeah.
And so, hey, we got listeners out there. We're crowdsourcing. The queens are asking you, what do you see? What do you see? What are some of the comments? What are some of the questions you're going to ask? What do you want us to do next, right? Where do you go from here? Because when I saw this individual, I knew something was wrong. To your point, Davida, I was like, she is compliant with her medication. She's telling me that. She feels like she's all over the place, which means when she's checking her blood sugars in the afternoon, she's seeing high numbers.
Yes.
In fact, when I asked her, she even said a little bit more than she realized. So here was where the fun part was. I brought her in, I showed her, I actually in my head was like, oh my gosh, I'm dealing with something different here. And I said, what do you see? Because I always like to do that. Every time a person comes in, I want to say, what did you see with this particular CGM? She had no idea that my blood sugars went so high. I had no idea that food affected me so much. You know, what are the biggest benefits that you see? If you could just give top line thoughts regarding CGM.
Top line is people truly begin to realize if I do this, this is what happens. If I eat this, if I exercise, if I take medication, these are the results. And they could not figure that out with finger sticks. They could figure that out and they begin to see trends.
Shows you all the places you go.
Yeah, I think we have to remember that CGM is synonymous with behavioral change. And that is huge for our patients. If you see it, they can make all of the behavior changes that you talked about.
Well, when I looked at these and I engaged with her, I had this little tiny spidey sense. It's the queen sense, right? That something wasn't right. And so what I did is I said, have you ever been tested for type 1 diabetes? And so I tested her and lo and behold, she was positive. And I brought her back in and I said, I got to tell you something. You're type 1 diabetic. And she says, what does that mean? So Jen, what would you do next with her?
Well, in a perfect world, I would send her to Davida to get an insulin pump.
Send her to the ultimate queen.
Queen would put her on an insulin pump, but I would have a conversation. The difference between that, she doesn't need all the other meds, but she needs insulin. And I would talk about multiple daily injections and an insulin pump and say, what do you think? What would you like?
So just not to make the one queen being shouted out, Jen's patient just shouted her out too.
Aw.
So, which is great. I love that many of those individuals that see us and that
Yeah.
interface with us and do all that. Okay, Davida, your turn. What
Oh,
would you
she's
do?
an absolutely pump patient.
Yeah.
I mean, I do use insulin pumps in type 2 diabetes as well.
Mhm.
And we'll see that more and more as things go by. We've done enough research for that and guidelines. But this patient has type 1 diabetes. And think about an integrated pump with a sensor and a pump
Mhm.
that talk
Mhm.
to each other that
Mhm.
can help her manage her diabetes.
That's exactly what I did. And I want to really point out a couple things too. This was a person of advanced age, had limited technology, had really been fixed dose insulin, knew nothing of carb counting. I was going from like A to like Y on her. And I said, would you feel comfortable if I put you on a pump? So I went through all the different pumps, the features, because I do believe, as well as the queens believe, you got to match the technology to the person.
Yes.
You got to make sure that they have the one that feels best for them. With a couple days of onboarding, we did put her on a particular pump with an AID system and a partially closed loop hybrid. She does work alone. It took us a couple days to onboard it, but it was great. We did it in steps. And then I saw her as a 2-month follow-up. And guess what her A1C was? It was 7.1. And she said to me, I have never felt so good in my life. So, Jen, what do you see?
When she started, she was 8% time in
Right,
range,
yeah.
77%.
2 months.
No wonder she feels better. And if you
Yeah.
just even look at that graph, she is just practically perfect. I'm not surprised that she feels better. My queen, amazing.
Yeah, that's awesome. You know, also just for the audience, for those of you that are not as familiar with pumps, AID means that it's integrated so that the pump and the sensor talk to each other, and our sensors are accurate enough that it tells the pump what the glucose numbers are, and the pump is programmed to give insulin. That is phenomenal.
Yeah.
That is phenomenal.
And it really goes to show that you have to find the right diagnosis,
Right.
the right therapy. It may take a little bit longer to get somebody on board. It is not, age is not a disqualification for technology. And, you know, she now feels, as she says, I don't have to focus on my diabetes as much because I have something that's watching me. And, you know, Jen, I'm sure you have stories like this as well of that value and utility of CGM.
If we even think about last week, so that interestingly, so I mean last month, so last month I talked about a patient who was misdiagnosed as a type 1 for 10 years. And with CGM, just like with this, you put CGM, this one misdiagnosed for all this time with type 2, both situations, CGM really gave us those answers.
We didn't know. We knew something was wrong.
Right.
Let me ask you a question. So even if you didn't find her to have type 1, would you have given her AID?
Oh, for sure.
Yes.
For
Yes.
sure. You know, because what we really want to get across is this. Something didn't make sense.
Right.
She qualified for the standards of care for CGM.
Absolutely.
And so CGM to me was the next step.
Yes.
It was the necessary step because I didn't expect necessarily to see type 1. I kind of thought that, but I needed more information. I needed to know where she was going. I needed to figure it out. And so for me, that was that next step, to be able to look at that. And so we were following the standards of care. And, you know, I would continue to do that for her.
Yes.
And I would then still offer an AID because of her being alone and that kind of thing. So
Yeah,
absolutely.
and I want to encourage everybody to look at the standards of care. So it's available as an app, it's available online, and it's a living document. So every time we have updated data, updated information, it's going to be updated in real time. And the other thing is, we need to not blame the patient. If it looks like a duck and walks like a duck, which we've shown these last couple of cases, we have to investigate that it might be a duck and not a zebra, and really appreciate that, believe our patients, certainly CGM. And we need to utilize a team. It's not just all falling on physicians. It's a team. It's clinical pharmacists and nurse practitioners and MAs and the front desk. It's everybody has to be part of that team, and community pharmacists as well, who might be the last touch point.
So the one thing that's consistent about everything we've said today and our 2 other episodes is CGM first.
Yes.
When you meet that patient, give them CGM. If you don't think they'll qualify for personal, give them professional while you try to get them personal. Even give them professional while you're trying to get them personal if they qualify. But CGM first for all of our patients.
And there's so many resources, and there's so many members of the team, and we always want to include, our PharmDs, our CDCESs, because, it's CGM first to give you that guidance of where to go.
Yep.
Well, we are coming to an end of our discussion. I know it's always so quick.
We got about 5 minutes.
So, good. So we have time for questions.
Yeah, so if there's any questions that come in, if you have any comments, anything you want us to address.
Absolutely. You have 5 minutes of the Queen's time. And so we want to remind you to put in for the next few minutes those questions. Hey, we'll take any CGM questions that you got. We want to know what's meaningful for you. We want to know what you want to hear, how you want to address it, some of those barriers and hurdles. We hope that this case has been amazing to help you remember the standards of care and put a face on it. We all have those individual types of faces. Now, remember, you want to rewatch this, repost it, send it to your family, your friends, your colleagues. Remember, you can do that. You can find all of these on YouTube. You can find it under the Medscape playlist. Please hit the like button and subscribe. Us Queens want to know that we're helping you out, that we're giving you that information. But remember, next month, July 22nd, the Sugar Queens will discuss how to use CGM data for medication adjustments. Mark your calendars, pre-register on LinkedIn, and think about any challenging cases. Bring it to us. We've been doing this for a few months now. We're ready. We're ready for the cases and the questions that you have about CGM, and we would love to answer them. I will be kind of sad, though, because I won't be with my Queens. I'll just have to be virtually with my Queens.
Oh, yeah, this was wonderful.
To be able to be together in the same room. Absolutely.
Yes,
excellent.
yes. So we do have a question in here a little bit that I want to tee up, and that is, when you have an individual that is in the standards of care, they're on the basal insulin or they're on one or more per day, Davida, can you run us through real quick? Do you have to do finger sticks and send them in? Like, what do you typically do when you identify that individual? How do you get that covered for them?
So most insurance companies no longer require finger stick data.
Great.
Medicare doesn't do that. Most of your Medicaids and most of your commercials, I think we're past that. In a rare case, maybe, but they're past that. They really want to know what their medication is. So so document it in your chart. That's what I tell people. Just make sure I saw the patient. If they're doing finger sticks, put it in there. If you have data, put it in there. If they're already doing CGM, put it in there. But what they're really looking for is how many injections are they on of insulin a day. Now, the other thing to understand is that some insurance companies, not Medicare, but some insurance companies are paying for people that are on multiple therapies that are not insulin. Also, if a patient has a history of hypoglycemia and you have intervened and you can't get rid of the hypoglycemia, you can often get CGM even if they're not on insulin.
Oh, that's a great overview. So one other question we have, Jen, is you're talking about getting these data, and somebody wanted to know that AGP, like where do you get this data from? Yeah.
So if patients themselves can look at their information on the cell phones, if they're using that individually, but we can set up portals for Bluetooth enabled for CGM data to be sent to us. And, just this, it's not overload of data. It's when we decide to look at it, whether it's right before a patient appointment, so we can do it in the visit, in that patient appointment, or your medical assistant, depends on how you set up your workflow. Exactly.
Yeah. And so we can tell that there's interest in CGM. We've talked about how you can acquire it, you can identify it. We're going to go into some further detail on a lot of these topics in future Queen moments as we get together. But I think, if we could come down to kind of that one big barrier is, that time barrier. And so create your workflow.
Yes. You
want to do CGM, you start with professional, but identify it, take a few moments to get that workflow going, make sure it's successful, and you are going to find how much more time you have in engaging with your persons with diabetes. And so thank you so much. I want to make sure that you can claim your CME or CE credit. So please scan the QR code on this screen. And on behalf of the Sugar Queens, I'd like to thank you for participating in this activity. We look forward to seeing you again in July. Please go ahead and get ready for us the next month as the Queens come back again.